Thanks, Becca. So we now get to use these freshly cleaned chairs. So if I could ask Ailsa, Ruth, Rachel and Becca to come up and choose. One of them looks slightly broken, so maybe avoid the slightly broken one. And we've got a microphone there. So we'll just take questions from the audience. So if anyone has a question either related to what was in the presentations or just more generally, please raise your hand. We have a roving mic going around. Who's going to start us off with the first question? Everyone's too scared. Okay, I'll ask the first question. Oh, Sue, thank you for coming up as well. Yeah, thank you. Okay, so the theme seems to be we're doing lots of stuff really well, but we could be doing much better. And we seem to be doing quite well proportionate to other areas of the country. But there is a very consistent, but we need to do more, we need to do better. So possibly one from each of you. If we could do one thing better, what would that one thing be? So Ailsa, you've got the microphone, start with you.
Oh gosh. I want you and your help so that every trust has got a Ruth and every trust has got a Jim Mackey. And I think for me, leadership is really, really crucial here. And we need from bottom up, I mean, everybody can be a leader, but I think we absolutely need to keep reinforcing if there is one clear, tangible thing the NHS can do to tackle this thing in inverted commas called health inequalities, it's smoking. So we need every medical director, every chief nurse, every chief exec and every director of finance, I think, to absolutely recognise this. And you know, I'm not going to apologise. I've been in meetings recently where I've had to keep saying, you do know smoking causes this, or you do know smoke. And I could see people in the room like, oh, here she goes on again about smoking. And actually, please don't ever feel like you have to apologise to keep banging on about smoking, because it is the golden thread that cuts across so many other things. So I would really like all of you to be feisty and to just keep reinforcing that. So thank you.
Thank you. So I think there's two things for me, really. Let's keep focused. We mustn't lose focus now. Just because it's going well and that line's going down, it's not going to take care of itself. It's probably going to get harder. And we know that when we look at the incentive scheme at South Tyneside, for example, that went incredibly well. They set the way and there was huge reductions in smoking at time of delivery. But then it began to plateau, and that was because the incentive scheme can only do so much. It comes down to relationships. And what we've seen reflected in that last quarter one data, even though it's quite early, they've started coming back down again. And that's because they're based in the community. They've got them really rich relationships. Big shout out to anyone working in that area. It's making a difference. So we've got to keep going. Treat people as individuals. Really unpick that. Use your partnerships to drive home your messages and keep going.
I agree with you. You've got to keep going. And yeah, definitely you have people look at the bigger picture. You know, digital is great, but believe me, it wouldn't have worked with me to quit smoking. I did join some teams, some groups, but once that group finished, I started smoking again. So it's not just about that immediate quit time. It's about keeping in touch with them and giving them the confidence to do it on their own.
Thanks. And just to add to that, for me, it would be around the data. Let's just write it down, record it, collect it, whether it's qualitative, the stories of patients who, you know, the interactions you've had with them is making a difference, lives are being changed. Just capture it in any form. And obviously, we need to be tighter with the quantitative because that's what people look at who are making some of the decisions, but just data. Let it not be the thing where people think, data, oh, I can't deal with that. Everyone can.
Absolutely taking the words out of my mouth, but I think, you know, if we're recognising this as a clinical condition, we're recognising it and treating it. In any other clinical service, you would be evaluating how well you're doing it. So recording it and tracking outcomes and working out how you do that so you can robustly say, we did this much for this many people, gives you the opportunity to then say, but what about And so the bottom half of those sausages, or the of the people who weren't contacted or didn't get a follow-up or a quit, or Becca's point about non-engagers, doing incredibly well to get smoking at time of delivery right down. But what about that last 8%? They're tricky and they need all of our time. So in order to understand them and focus in on them, we need that rich, robust data. So leaving no one behind. And the secret to that is having really high quality, robust data.
Okay, thank you. Any hands going up for questions? We've got one down here. Sorry, do you want just hang on a second for the microphone? Thank you.
It's slightly related to data, but the partner incentive scheme. So Nicola's here, my local authority colleague. We're looking at ways to support partners all the way through pregnancy, but it feels like we're working a little bit blind. So how do we record it? Who's responsible? Is there anything from the Smoke-Free Task Force that can support that joined up working and the data that we want to share?
Yeah, in a nutshell, no. So, yeah, it's been discussions that we've had probably for the last 3 or 4 years. Maternity systems sit quite separate to everything else, where we're recording interactions around pregnancy quits is on the maternity data to try and streamline that for staff. Other than us moving to a generic system like local authorities originally had, that could be a possibility, but there has to be a willingness for that change. And up to now, we've just been trying to get the house in order in each of the trusts. But, national incentive schemes coming, opportunities there with the new recording system, may be a lot easier for partners recording on there as well. So I think we've got opportunities on the horizon, but yes, it has been really difficult in regards to that.
Okay, thank you. We've got another question. Yeah.
Hi, Jojo. Thank you. It was just to kind of respond to Carla's question and to Becca. So at Gateshead, we do exactly that, Carla, because we did recognise a huge gap there, particularly with our partners of pregnant people. And so linking with our local authority and using Fire Caller Quits, we kind of commissioned a service for us to deliver that. And so we reach 100% of our pregnant partners who want to be part of this, but we could talk about that.
Okay, great, thank you. We've got another question up at the back there.
Hi, we focus a lot on maternity and inpatients, which is what we're all funded for, but we've got a lot of our local people who come from the inequalities group who are coming into outpatients all the time, and we're not focusing on them. Is that something that the task force is going to start addressing? Because obviously we're all missing a massive trick by not having teams in the outpatient departments.
Try and answer it. Yes, it's always on the horizon in terms of what else. And like I mentioned in my talk, there are so many gaps in terms of the interactions the NHS is having and those opportunities we're missing. So definitely within the next year, that will be one of our things that we look at and how we can support the system.
I think it's a brilliant question, and I think you're absolutely right. Long-term plan was very clearly focused on those 3 pathways, but I think what I would say, and I'll say it before you and Dash's off, is smoking as a priority is here to stay, and this task force, hopefully you can all see the phenomenal leadership and the huge support we've had from the ICS, the amount of work that's been done, but we need to keep it going. So I think what I would really welcome from you all here is your work locally is really, really supported by the work here, and we absolutely know there's so much more to be done. Primary care, outpatients, this is 15 years worth of planning ahead. So I would just really like to feel like the commitment will be there to just absolutely say, this is working, you're working, but we need to, be really bold now and expand further.
Yeah, and I think that links back to Rachel's point about the quality of the data. It's so much easier to make that argument if we've got the good quality data that demonstrates those outcomes.
I was just going to add, the point is, it feels like we're completing some really important pieces of the jigsaw, but as per Rachel's slide, the people at the heart of this are all the same people. So we might be, really focusing on this bit or that time when they were pregnant, but postnatally or when they come in outpatients for a complication or a follow-up, when they go and access community services or in social care settings, it is all the same people. So we've put some pieces down. We need to make the whole jigsaw complete, don't we? And you're right, and we see that. But I think we have built some of the foundations towards that. Staff on wards in the morning are having the same conversations in the afternoon. We're just having to use different pathways or might not have quite as much resource, but the institutional language and narrative has changed. And I guess the next steps just have to build on that and reinforce it. But really good question. Thank you.
Okay. Any more? Oh, we've got another question. Thank you.
Hi, this is more of an ask than a question. I think most trusts struggle with frontline staff asking those questions, which is something Sue talked about. And I think something that would really benefit our trust and probably some other trusts would be Sue recorded saying what she said. I think that would be really, really powerful, and it would hopefully engage frontline staff and ensure that they do ask those questions, they do bring it up.
It's been filmed. However, I also believe that it's training on how to approach a person. As I said, Sunderland University do it where we'll do a role play where we go, no, I don't want to quit, I don't want to quit. And it's up to the students to actually try and get that person. And believe you me, I don't give in easy. But they do some students do an amazing approach where I would have possibly thought about quitting. So it's about teaching staff how to approach a smoker who's adamant not to quit.
So our trust, we have mandatory training, so that all have to do very brief advice. So all frontline staff must complete it every 3 years. We managed to get that in when we went smoke-free. But I think your video would support that and help that. I know Graham does public health lectures with frontline staff within the trust. That tagged onto that, whether it would be in staff ward meetings, things like that, just to prompt them to ensure that they are. And I think it would be an amazing addition. So it has been recorded, whether it can be cut, so we could use that.
Yep, that's why we're filming everything today. It'll go on YouTube. We will be sharing it. I think it's a great idea, Sarah. I also think we need to continue to advocate, and I'll ask you to help as well, is because we're training people often after they've finished their degrees and things. So I'm a nurse by background, and I did a wonderful nursing degree. In 4 years, not once was smoking ever mentioned. Mind, I'm very old, so it was a long time ago. But actually, a plea I'm going to make to the CMO as part of his legacy is, why is it so hard to convince all of the Royal Colleges, particularly nursing, midwifery, medicine, for a consistent approach, at least in England, that everybody comes out of their undergraduate degrees knowing what to do, and not a 30-minute ticky-boxy prevention module. Actually, really, I just think we need this top-down and bottom-up approach. So any help that Liam could do actually to be making the case, and even if we can just get in the North East our wonderful universities to agree to do it. Sunderland, you're doing fab. So is that happening across the others? I don't know, and nobody seems to know how to ask how to make it happen. So thank you.
Yeah, I think it's a good point. So I'm involved in Teesside University. They're setting up a new school of pharmacy. And the way they're setting up the curriculum, year one is about teaching them what a healthy patient looks like. So they don't do what I learned was big lists of drugs and big lists of side effects, and I had to memorize them all. What they're doing is, first year is, what does a healthy person look like? And everything comes from, if that person isn't healthy, then you know what to do about it. So it's going to introduce that much earlier, and I think that's absolutely right. Sue's point about making sure everybody feels comfortable having the conversation in an appropriate way, rather than just deferring to, well, that's a specialist thing for a specialist team, someone else has to do that. It has to be a core part of what every healthcare professional thinks and says.
Can I just add, absolutely at scale, nationally, Royal Colleges and medical schools, universities, but at place you will have clinical teaching sessions, and we're saying this is a clinical condition. So in Gateshead, we take it out to the junior doctors when they're on their training. They get protected training time to discuss challenging clinical cases, and sometimes they all come and they seem desperately young and they sit on their phones, and you start to present a case about a patient and the impact you can make when you deliver this type of care in this way, and support them with something that they thought was not on their radar to ask about or to help with, that that's not for them to comment on, and you get so much engagement. It's far far better received than when I'm doing a lung cancer update or an asthma update. So reach out, you know, in terms of clinical groups, junior doctors, the consultant grand rounds, they will welcome you with open arms to bring cases, to bring the frontline staff. That's normally who I take along to mine to sort of share what they're saying, what the options are, how the conversations go. Everybody gets really engaged and feels quite empowered by it. So there might be other avenues at place as well as everything everybody's suggested.
Okay, we're just about finished now, but I just want to take, well, chair's prerogative. I don't think I'm chair, but I'm going to take this opportunity to just, because so much of what we said today is about leadership at all levels, local leadership, clinical leadership, national and everything. And Ailsa, one of the things you said was you wanted every trust to have a Ruth and a Jim. And so I'm going to embarrass Ruth slightly by saying I suspect you didn't go into this because you thought, well, I like standing in front of a group of people and talking about things. I suspect you went into this because it was a clinical area you were interested in and you saw that something needed doing and you saw that you had a role as a clinician in influencing that. So is there any advice you would give to other people about, and again, picking up on Ailsa's point about be feisty, keep talking about it, don't apologise for saying this kind of stuff. Is there any reflection from you on your career up to this point that would help others to feel confident in doing that?
I think it's fair to say it's a real challenge. There's definite fatigue and there's so much other pressures on our operational partners in place at delivery against so many targets that tobacco just becomes one thing, and as Ailsa says, sometimes you're like, oh, not her. So you need to find your allies. You need to say, this isn't just me talking about lung cancer, this is the vascular surgeons, it's the diabetes team, it is everybody, everywhere. It's your elective recovery, your winter plan, get it into everybody's conversation and channel ongoing energy and commitment to keeping it on people's radar, show it to them as a solution. You know, this is how we get out of these problems, this is how we make judicious use of limited public resource. We do cost-effective, acceptable interventions to people who need it most. So find your partners, I think.
Excellent, thank you. Okay, so it's time for a caffeine break now, but I would just like to encourage everyone to say thank you to all of our speakers this morning.